This is Miss Harlan discussing lung cancer, which is the very last part of Chapter 30. Lung cancer kills more people in the year. I'm so sorry. Lung cancer kills more people than prostate, breast, and colon cancer combined. The overall 5-year survival for all cancers with lung cancer is only about 16%, and this is because the majority of the lung cancers that are diagnosed in their late stages, and the majority of the time metastasis, which is where it goes to a different part of the body or a different organ, is present. Only 15% of patients have small tumors and what we call localized disease. That means the tumor is only in one place at the time of diagnosis, and the 5-year survival rate for this particular population is right about 52%. This picture shows you a nice picture of both of your lungs here and all of the particular lobes, and you see this nice little cancerous mass up in the upper lobe here. So again, lung cancer is the leading cause of cancer deaths worldwide. It has a poor long-term survival rate due to the late-stage diagnosis. Bronchiogenic carcinoma is basically a failure of the cellular process to regulate in the epithelium that lines the bronchus. And these cancers are collectively called bronchiogenic carcinoma. You don't really have to know a lot about that. Know, though, that lung cancers are classified as one of two different types. You have small cell lung cancer and non-small cell lung cancer. And Chapter 21 discusses this a little bit better, but I'm going to discuss part of this. The lung cancer is staged. Most of your cancers are staged generally on what we call a TNM basis. T stands for where your primary tumor is. N stands for the number of lymph nodes that are involved. And M stands for whether you have metastasis or not. Is it still in the same area that it was in? Has it spread into the bloodstream? Has it spread into another organ? And the higher the numbers are in that T and M, that means the worst stage that particular patient is in. Like you could have a T of 1, an N of 2, and an M. So that means the primary tumor is pretty much localized to one area. You have 2 lymph nodes involved, and you do have some metastasis. If there is a 0 next to any of those letters, then that means that those are in the early stages. Lung cancers can occur as a result of repeated exposure to inhaled substances like cigarette smoke, asbestos, anything that is brutal to the system. Anybody who's worked in coal factories, petroleum plants, radiation, uranium, anything along those lines. Also realize that secondhand smoke is apparent as well, and it can affect you just sometimes as poorly as smoking yourself. Non-smokers exposed to passive smoke have a greater risk for lung cancer than, of course, non-smokers, so it's really good as you're in your day life and hanging out with your friends that you not really be involved around people who are smoking, because it does put you at risk for developing lung cancer. There are, of course, genetic risk. If you can be genetically have a genetic disposition for cancers. The more factors that a person is exposed to, the higher risk they run of developing lung cancer. Assessment wise, we need to know that patient's history, have what their occupation is, and do they smoke, hazards in the workplace. Again, we also, if they do smoke, need to calculate their pack per year smoking history. That does play a significant part in how well sometimes the chemotherapy work and how at risk they are for complications. Ask about the signs and symptoms they're having: hoarseness, cough, sputum production, hemoptysis, shortness of breath, or if they're just having a lot of fatigue. We want to document all of these signs and symptoms. Assess for chest pain or discomfort, which can occur at any stage of the tumor development. Chest pain can be localized to just one side. It can be range from mild to severe. Ask them if they're having any tightness, fullness, pressure in the chest, and yes, some of the stuff can mimic heart attack, but it also may suggest obstruction. Chest pain or pleuritic pain, which is piercing, can occur on inspiration. This sometimes can indicate a blood clot, and then they can have pain radiating down to the arm, which can result from a tumor invasion as well. Psychosocial, we definitely want to let these patients voice their fears. Again, this is a poor prognosis. Shortness of breath and pain can add to the patient's fear and anxiety. A patient who has been smoking for 50 years may have some, feelings of guilt. Again, we need to convey an acceptance and interact with the patient in a non-judgmental way. Encourage them to, and their family, to express their feelings about this particular diagnosis. The diagnostic assessment is made by an examination of the cancer cells. So what they must do is go in there basically and do a lung biopsy so that they can identify the number of tumor cells, what they look like, and see what type, whether it's small cell or non-small cell. They can also, physician can also go in and do a thoracentesis, and that's again where they get a sample from the lungs itself and to check that particular cytology. Most common lung lesions are found through a chest x-ray or a CT scan. Then after that, if they deem necessary, they will go ahead and do a biopsy from that particular examination. So I found this picture and I really, really liked it. And we're going to talk about non-surgical management of lung cancer. It says, what is chemotherapy? Chemo means chemical, and therapy means treatment. Chemotherapy refers to medications that kill cells that divide rapidly, one of the main properties of most cancer cells. So this means that it kills and harms those cells that divide rapidly under normal circumstances as well. Some of these cells are your bone marrow, digestive tract, hair follicles, nail follicles, any of that smooth tissue that lines the inside of your abdomen, the inside of your throat, your mouth, the tissue that lines your rectal area. All of these are rapidly dividing cells. So that's why you have common side effects of course, all of your red blood cells, white blood cells, platelets lower, inflammation of the lining of the digestive tract, and hair loss. And this picture states this is what this particular person was expecting, this nice little nurse hanging the chemotherapy. And what she actually got was this person in a gown, a mask, gloves, and that's primarily so that we as oncology and chemotherapy nurses can help protect ourselves. Not necessarily so much that particular patient, but we want the chemotherapy inside the patient, not inside our body parts. So non-surgical management, and again, some of the side effects of chemotherapy are fatigue, hair loss, which may be permanent or not permanent, loss of appetite and mouth sores. The loss of appetite comes a lot from the mouth sores. Nausea, vomiting, diarrhea, again, from the fact that you have all of those skin cells changing rapidly. Skin changes, sometimes the nails will darken, some the skin can get a little bit thinner. Potentially serious side effects, bleeding or bruising because of low platelet counts, low blood cell counts, and of course you're at increased risk of infection because your white blood cell count does get so low. So chemotherapy, depending upon the type of cancer that you have, can depends on whether the particular therapy will be harsh to the system or not. Certain types of chemotherapy are more what we call emetogenic, which means they make the patient more nauseous. Certain types of chemotherapy will lower the blood counts than others. So it is always good to make sure the patients have nausea medications at home. Most chemotherapy regimens, patients are given um, things like Zofran and Kytril and Protonix prior to the chemotherapy itself to help with it, and then we keep them on a management of making sure that at least for about the first 24 hours or so that they're staying on their nausea medications to help with that. Targeted therapy is a new term for certain types of medications, and it basically focuses on certain parts of the cell cycle. And these particular medications take advantage of the differences in how the cells grow or their metabolism. And what it does is it goes in there and it targets and it blocks that growth factor, therefore slowing down the growth of that particular cancer cell. A couple of names of these drugs that are that help to treat non-small cell lung cancer are Tarceva, Avastin, and Xalkori. Radiation therapy can also be used for lung cancer. It is best for locally advanced lung cancers that are confined strictly to the chest area. This means they have not metastasized into other areas. You see a synergistic effect when radiation is used in combination with chemotherapy. And radiation may also be used prior to surgery to help shrink the tumor. Therefore, when the surgeon gets in there, they don't have as much tumor to remove. And it also helps to make resections a lot easier. Most radiation therapies are performed for like a specific number of treatments. It can be anywhere from a 5 to 6 week period to a little bit longer. And they only radiate the particular area where the tumor is. Realize that you can still have side effects from radiation. You can have skin irritation and peeling from around the radiation site, still have nausea and vomiting and taste changes. And a lot of people, depending upon what area they're radiating, can have a really bad sore throat. These patients need a dietary consult to help them teach them to eat foods that are soft and bland, and of course high in calories. A photodynamic therapy is used when you have very small lung tumors and when they can be accessed by doing a bronchoscopy. You don't have to really know a lot about that, just know that that particular therapy is available to help with lung tumors. Surgery is I'm going to the next slide. Surgery is the main treatment for stage 1 and stage 2 non-small cell lung cancer. If the physician can get the entire tumor, then this can result in a cure for the patient. If they cannot, then they can do what they call a complete or a partial resection. It does depend on the stage of the cancer and how the patient is doing overall. Are they relatively healthy besides this lung cancer? Or do they have other comorbidities that may not make them a good surgical candidate? Removing only a partial removal of a lung segment, or you can remove a lung. A removal of the lobe, one lobe of the lung, is called a lobectomy, or if you remove the entire lung, it's called a pneumonectomy. You don't see patients with an entire lung removed most of the time. They only try to remove a lobe or a section of it. If they remove just a small section, it's called a wedge, WEDGE resection, and they do this to try to help control the disease processes. The focus for these particular surgeries is to, help the patients with their anxiety and making sure they understand the entire surgical process. A segmentoris, I can't even pronounce that word, segmentectomy is where they go in and it includes a lung resection that includes the bronchus, the pulmonary artery and vein, and then tissue involved. So that's a pretty large surgery for a particular patient. They do, again, wedge resections when they can just, when the tumor is combined to a small localized area. That means it's just in one place on the lung. With the majority of these sections, realize that this patient is probably going to have a chest tube. And this slide shows the chest tube placement. The top part here, if the patient was having trouble with air in the lungs, then they would place it up here. If it was like a punctured lung and then there was blood, then they would put it down here. You will see more chest tube placements placed in this lower half here. So the chest tube chambers, and the next slide will show the chest tube drainage system in just a moment. But the chest tube is placed in that smaller area on the patient's either the left or the right side, depending upon which lung they can get into easier. What the chest tube does is it allows for lung re-expansion. It also prevents air and fluid from returning back to the chest. The drainage system consists of one or more chest tubes or drains, and you always want to make sure that your chest tube is below the chest level and that the water seal is there to help keep air from entering the chest. The way you know that the water seal is working is it bubbles, and I will show you that on the next slide. Your drainage system must really be stationary and a self-contained system, and also disposable. We don't really see any non-disposable systems anymore. Our nursing priority focuses on making sure the system is closed, promoting comfort for the particular patient, and ensuring the chest tube is patent and the patients don't have any complications. So this is the chest tube drainage system. This is the water seal right here, and it normally always is bubbling. This is a collection of blood starting, and the book says to do an hourly drainage measurement, and what we do as nurses a lot of times we'll just take a black Sharpie marker and mark beside the line and maybe put the time, or put 7 to 11 or 11 to 4. Most of the time on the floor we'll do every 4-hour drainage output. Again, this is a one piece, and it is a disposable. When the physician takes it out, then it's just disposed in a hazardous container. And this is considered a closed device. The tubing does allow for the patient to turn and move without pulling on the chest tube. Again, you always want to make sure it stays below the chest. The tubing from the patient, one chamber will collect the fluid drainage from the patient, and this fluid is only measured during the first hours. You also want to make sure, if you have a lot of drainage from the chest tube in a short amount of time, that you need to let the particular physician know. Chamber 2 is again the water seal, and the water seal prevents air from entering the patient's pleural space. So as the trapped air leaves the pleural space, it passes through chamber 1 and then enters into chamber 2. And the bubbling in the water seal indicates that the air is draining from the patient. So you always want to see bubbling in that particular water seal. Chamber 3 is the suction control of the patient, and there are different types of suctions. They could have monocontinuous or an intermittent. It just depends on what the patient needs at that time. So interventions for palliation. This is when the patient is either gone through chemotherapy and radiation or gone through other interventions and they're not working. Oxygen therapy, we want to make sure that the patient is comfortable. Also, one other thing, back on the chest tube slide, you never really want to vigorously strip the chest tube. Sometimes you need to strip the tube to get old blood that's sucked in there to go into the chest tube, but you do that on a very you don't do it very often. In fact, your book says never to strip the chest tube. Sometimes you have to every once in a while, but for the most part you do not want to do that. Okay, back to palliation. Oxygen therapy to make sure the patient is comfortable. They specifically need oxygen a lot of times for the first couple of days after surgery. You want to warm and humidify the oxygen. Patient needs to sit in a semi-Fowler's position or up in a chair as soon as possible and as much as possible. Need to be using their incentive spirometer to help those lungs open back up. If they are allowed to cough, have them splint the incision, ensure that the chest tube doesn't pull away with movement. We want to help with pain management, give the medications when the patient needs them as often as they need them. Drug therapy, bronchodilators to help open up those lungs, steroids to help with inflammation, mucolytics to help ease the thick mucus in sputum, and antibiotics if necessary to help with bacterial infections. Again, we've already talked about radiation therapy. Thoracentesis and pleurodesis. Patients who have lung cancer are at increased risk for getting fluid on their lungs and also fluid in their abdomen a lot. So it may be necessary that for them to have a thoracentesis or a pleurodesis. Thoracentesis is just removing fluid after a large needle is placed into the intrapleural space in the lung. The fluid remover helps the shortness of breath that the patient has, but a lot of times the fluid does rapidly reform, so sometimes this has to be done multiple times. Sometimes they can place a continuously draining catheter in there so that the patient can do this at home. Again, we need to manage the dyspnea these patients have. They can tire easily, they're uncomfortable, they can't rest, they have to sit in a semi-Fowler's position. So we help that with oxygen. We help that with giving them morphine sometimes, because the morphine, number one, it helps with the pain. It also helps with the shortness of breath, reposition them. And a lot of these patients may be more comfortable sitting up in a lounge chair or reclining chair. We may need to be giving these patients TPN or PPN to help feed them. Of course, PRN medications for breakthrough pain, and then in the final stages, hospice can be beneficial to help keep these patients at home and keep them comfortable if that is what they wish to have. So that concludes our slides on lung cancer. Thank you.